Thank you.
So this is the last little bit, you guys, because we're going to talk about sort of how to have or some strategies for talking with families, and then Mike's going to kind of wrap it up for the afternoon and we'll get you out of here. But we do hope to really kind of get a sense of how, beyond the screening tool, beyond the resources, how do we actually try to have some really useful conversations, effective conversations with families. And my guess is many of you have done sort of training or at least practice and have your own experience with motivational interviewing. Who's done any formal kind of, education or talk on motivational interviewing? Expert. There's lots of different names for the same process. Who actually struggles with maybe incorporating it into their clinic flow? I know I certainly do at times. That is certainly part of what we hope you're able to get out of this particular program, is figuring out those small little sort of tweaks and changes and sort of useful nuggets that we can incorporate when we're talking with families, specifically when it comes about smoking or vaping cessation. And there are a lot of barriers. As a clinician working in the clinic, I see them as well in terms of providing smoking cessation assistance to family. There's often a time crunch. Especially as pediatricians, we may not always sort of think of, at least from a medical aspect, of parents as our patients, or certainly when it comes to like giving medical advice or nicotine replacement or things like that. We also are really, especially for these young babies, this may be the first time they're in our clinic. So we're trying to really forge an alliance and a relationship with them. The last thing we want to feel like we're doing or give them the impression that we're trying to do is alienate them. That's certainly not what we're trying to do. We also, know that at the end of the day, what we're able to do and accomplish in the clinic has, in part is about how much we can get paid for that so that we can create the time to have with our families and our patients. So thinking about what are some of the strategies that allow us to maximize and be efficient about reimbursement when it comes to this type of work. And then part of what we hope you're getting out of today is really kind of addressing sometimes, which for many of us, just kind of learning about what it is, lack of knowledge in terms of what smoking and vaping issues are and how do we have conversations with families about this. Like we were saying, the reality is we don't have a whole lot of time, but the nice thing is it doesn't always take a whole lot of time to be effective. Even if it doesn't feel like we're being that effective, each little type of sort of conversation, each little tidbit we're able to get in, knowing especially as pediatricians how those relationships are sort of evolving and sort of move one after another. It's sort of that how that conversation evolves over time and how that information is able to really be filtered to the family to be effective. Because it really is an ongoing conversation. I work with teens a lot, so I think about this from an adolescent perspective, but it's no different than our other families, our other parents and our kids. When we're talking about, as much as I'd like it to be a quick, they're gonna leave at the end of that particular visit ready to quit or make some huge behavior change, it's those small little steps and that ongoing conversation that seems most effective when we talk about whatever behavior change we're talking about with whatever type of patient. Because at the end of the day, our common goal is the baby's health and well-being, and sort of re-emphasizing that message really helps go a long way to reinforcing that alliance. We've already Melinda talked a lot about the very real health complications and implications that come with smoking and vaping. And then, like I said, we do want to use some of the tools, at least, that we recognize are reimbursable and take advantage of those so that we can incorporate that as well into our clinic flow. We do know that smokers do tend to want to quit. About 70% of tobacco users will say they are wanting to quit. And they also cite that it's their pediatricians, it's their physicians, it's the health experts that they tend to go to and really sort of have a lot of confidence in when it comes to going for information about health implications of smoking. We also know that most of them have tried to quit. They may not have been necessarily successful with that one particular episode of attempt, but each of those attempts actually get them closer and closer to being successful. So the more time we can be in part of those quit attempts, the more effective we are in helping them get closer and closer to that ultimate goal of quit. Relapse is sort of a recognized aspect of the quitting process, but that means that the more attempts and relapses we have, the closer we're getting to hopefully that eventual success. Some of the research will also show us that though people can quit on their own without any involvement of a medical provider or anywhere else, about 7 to 10% will. More will, 13% will be able to go on to quit after they have had at least some types of brief message or intervention by healthcare providers. And that number goes up even more when we try to incorporate really what our guideline recommended treatments, some real concrete behavioral step improvements, referrals to quit line, referrals to sort of resources that help them through that behavior change process. Pediatric interventions in particular often include really asking about if they're using, really coming from the angle of trying to assess what that home exposure may be for those children in that room. And we're often probably on the right side of that, or left, actually, if you're looking at it this way, because we're usually focusing in on the counseling piece. Those at least brief, 1, 2, 3 minutes really doubles the quit attempts and successes. Even though they seem short, they're mighty. And that intensive counseling is even more effective than smaller brief interventions. So again, the more we can sort of build on these conversations, the more, the better the effect as well. The most effective types of counseling interventions when it comes to behavior change are ones that really focus on thinking about how to problem solve, and those problem solving skills that the patient themselves, or in this case, the parents themselves, are relying on or trying to build on, giving and providing that support to them as clinicians, and helping connect them to supports outside of our clinic space, whether it be something like the Quit Line or another resource that you have in your community. There certainly are medical support options as well. Oh, sorry, wrong way. Moving ahead of myself. There are medication support options too, like nicotine replacement, as well as a few medications that can be effective with nicotine cessation. Unless you're coming from a family practice or a meds peds clinic, you may not be involved in this aspect of a parental cessation efforts, but certainly we can help get them connected to those resources, even if it's a matter of just sort of having that message of, let's get you, why don't we have you have a follow-up appointment with your own doctor, so that they can help them through that process. And like we mentioned, the Ohio Quit Line, one of the options that they have is some free nicotine replacement therapy for adults. We have, and Mike has mentioned this as well, we've already seen that specifically the type of support we've been able to build in with this particular program in previous ways makes a difference, makes a real tangible difference in the amount of smoke and smoke exposure that the kids at home are getting, and making a real tangible difference in the adults in their lives and their ability to cut down and quit and create those smoke-free homes. And that's like our bread and butter in pediatrics is prevention. Thinking not just what's going on in our clinic, but what's happening, 5, 10 years down the road, and the real tangible effect we can have on the lives of everyone in those homes. I mentioned this sort of in the beginning that we were talking about motivational interviewing, but again, keep in mind they're all sort of cut from the same cloth, whether you call it 5 A's or change talk or motivational interviewing or whatever. We're talking about some of the strategies that we know can be really helpful in supporting positive behavior change, whatever that behavior change is trying to accomplish. but you have a few overarching concepts in all of these types of change talk patterns. It's really important for us as clinicians to just check our assumptions at the door, check our judgments at the door, and really be open to having really, you know, open conversations about struggles potentially that someone is going through, so you can also really get a sense of maybe what some of the motivations underlying those behaviors and be able to help them find out solutions that work best for them. It's really about proceeding with that same respect that you show every day naturally in the way that you're helping treat families and children in your clinics already, just sort of emphasizing that towards the parents that are also just as much wanting to create that healthy space for their child as well. And especially when we talk about behavior change work, we're talking about the types of conversations that are patient-centered, patient-directed, patients-determined. As much as sometimes it would feel like it would be easier if someone would just do what I ask, including my children, I wish they would do that. That like rarely ends up being the most successful route. But frankly, you know, it also may not be the most sustainable route anyway, because you really want it to be sort of coming from internally inside that particular adult. So, you know, our role as providers with this change talk and this motivational interviewing is really to help open up that conversation, provide information, kind of help them think through what their own sort of internal motivations and struggles and challenges may be, but also help them navigate through, you know, what their goals are and how to help get them there, oftentimes by using small little steps that build confidence along the way. So step one is definitely asking, and we're giving you kind of a very formal way of asking when it comes to the screening tool. Some of you have also mentioned that you already have some formal ways that you're asking about smoke and smoke exposure as well. Those types of screening tools certainly help often lead to a more standardized kind of universal way of screening. Those screening tools specifically also tend to allow us to at least have some sort of reimbursement vehicle, so that CPT code 96161, when you put it on your billing code or in your EMR when you get to that billing section, that's the code that is about parent-focused risk screening related to whatever that child is, since you're the pediatrician and the child's provider. That's the same code, for instance, that you're using for your maternal depression screening if you're doing that in your clinic. And that is reimbursable for clinicians as well. I'm not saying you're going to make tons of money off of it, but those screening tools often end up being somewhere around the $3 to $7 range in terms of reimbursement. Or some clinics are doing screening, and again, whether you're talking about smoke or whatever, in a more informal way perhaps. And again, the process being, at least for asking, like how do you do the ask? And then, like, as I was saying, with this particular project and with this particular sort of focus on smoke exposure, what we're trying to help our clinics do is get into the process of that universal type of screening with all of our patients. Even if at the end of the day, after the QI project is over, you're just really capturing 2 or 3 really important questions in this larger screener once you move forward into sort of your longer sustainability. Step 2 is assessing motivation and readiness for change. You know, asking this often involves asking a few more questions, but the sort of underlying concept is you're trying to understand where the motivation is. Why do they smoke? What got them going? Sort of what are the circumstances in which they smoke? And through this, you're also getting a sense of how they feel about it. Where are they in their sort of stage of readiness? So you saw on the smoking screening tool, there was that sort of question on the back side, that very first one that was asking sort of where they are in terms of their sense of wanting to quit or cut down. That's just one sort of objective marker that's often used with behavior change when it comes to assessing anyone's readiness for change of something. And one, as a clinician, it helps you, give you a sense of like how close are they to really wanting to do another big step here. But it also, more than anything, can also be sort of a jumping off point for further conversation. I see you're like a 5 on this scale that you said. What makes you say 5 as opposed to 3? I mean, it sounds like you're actually a little further along than what you said here in terms of not wanting to quit. Tell me more about this. So again, depending on how much time, sort of where your conversation is going, it may be part of what lets you sort of expand on your conversation about what motivates them and sort of what's going to continue to drive that desire for change. Step 3 is provide at least that brief intervention message that we are talking about. Remember, regardless of whether you don't have any more time to spare in that visit, because that's the reality sometimes of visits, or if the family just right off the bat is very clear, this is not a problem, I don't want to talk anymore about it, at least being able to sort of state out loud, saying, I know you and I both are trying to make sure that we're creating the healthiest home as possible for your child. And we want to be able to help do that. And one of the things that we know is important is at least trying to think about reducing that smoke exposure that they have in the home. The research will show us that a minimal intervention lasting, again, less than 3 minutes does actually make a difference in terms of abstinence rates that we see with families, regardless of where they are in that readiness for change. So at least offering that minimal amount of messaging, that 1 or 2 sentences about quitting smoking and having a smoke-free home is important for your baby's health. It's important for your health, and that's what we're here for, to be able to help in any way that you can. So when you're ready, we're just a phone call away, sort of message. You also, though, as part of the QI program, will have those resources available as well. The resources that families can take home with them, that gives them a little bit more information about smoke and the risks and sort of ways to quit. There's also a myths versus facts kind of resource in there, which we've heard in feedback is one of the most sort of useful, or one that families and clinicians often find sort of resonate with families. So those are all available, and of course this is going to do some fancy stuff here, but know that they're around and available to use, and that's what you're marking off on your screening tool when you have a family that does say that they have someone who smokes, or that there's someone in the family that smokes. That's where you're saying that, yes, I've at least offered, or even that they took the resources that they have, that you're marking on that list. Step 4, though, is having, if you have more time, or if the family is just like at that prime spot where they are ready for a longer intervention, then you want to take advantage of that as much as you can. So that conversation that you've been having already, and the further sort of questions that you're able to ask, one of the goals of that conversation is also to get a sense of where they are in that stage of readiness in terms of being ready to quit or cut down. And again, you've already captured some of that information, hopefully on that screening tool too, when they had that roller of readiness. But you're basically assessing, are they at the point of, not even thinking smoking or whatever behavior they're doing is an issue, or what we call pre-contemplation, all the way to, yeah, they're ready today to stop, and everything in between. And part of the thing to keep in mind with the stage of readiness is, it's not a matter of, seeing that they're in pre-contemplation and say, okay, the game's over, we're stopping the conversation here. But knowing that the way that drives where the conversation goes next, because then our next goal is just how do we help move them a little bit closer through the next, or closer to the next stage of that readiness. Knowing that really does drive behavior change in the long term. So there are questions you can ask to kind of promote this sort of internal dialogue and thinking that hopefully we're going to help patients go through. Questions that help you from them elicit what motivates them to smoke or to vape. Questions that help you help them develop discrepancy, that sort of sense of like, yeah, I feel this way, but yeah, I understand smoke exposure is bad and unhealthy. You know, how do I kind of come to some conclusion, or how do I sort of get through that discrepancy that I have? You also, you want to be thinking about questions or sort of pulling out reflective listening that helps them build their self-confidence in terms of what they've already accomplished that's been successful. How do they kind of take that confidence that they build and other small goals that they've set for themselves and sort of move from there and build on them. It often is helpful to talk about any quit or cutting down attempts that they've had in the past. One, oftentimes is a way to really congratulate them and boost that confidence of what they've been able to do. And also to kind of learn from it, or help them learn from it. You know, what were the challenges? What kind of made that easy for you at the time, or what was successful, or what were the challenges, so maybe next time around we can try to problem solve around those challenges. But also is where sort of having conversations about obstacles that they foresee, knowing that every time they go over to their sister's house, that's when they tend to start smoking, just because their sister also smokes as well. Like, knowing that's kind of a weak space for them, what can we do to kind of help them think through that challenge before they get to that point, especially if their goal is to start to cut down or quit, and problem solving around whatever those challenges may be. We've talked about motivational interviewing in terms of how the way it looks, but like I said, regardless of what name you use for it, there are some strategies or sort of useful tools that people who are doing change talk will talk about. Rule or oars or reads. These are sort of all little mnemonics, because all of us in the medical world are used to having mnemonics kind of remind us of things, but it's sort of the messages that help us think about how to build confidence or self-efficacy, how to use reflective listening and open-ended questions in these conversations that we're having with families, so we can hopefully be more effective during those conversations. You also have in your set of resources those talking points that I think it was Haley that was mentioning earlier. These are some of those sort of, you know, back of your pocket phrases or thoughts or little nuggets of information that you can have available in your mind, or even physically available if need be, to help you better navigate those conversations when you're having them with families. And then step 5, when you do have a family that's ready for behavior change, even if that behavior change is just cutting down, or, you know, knowing that they're just going to smoke outside as opposed to inside, or whatever that behavior change is, congratulate them on being ready for that step, and really help them kind of think through some of the potential obstacles, so that they can also be thinking about how to overcome those little obstacles, really emphasizing often small little steps of change, and really importantly, follow-up. So they're setting a goal. You actually already have built-in follow-up with these particular kids that are going to be in this program, because these are naturally happening at your sort of 0 to 1 year old well visit. So you know you're going to see them back in 2 months, whatever the thing might be. But, you know, really say that out loud. I know you're saying, okay, the goal is for you to cut down from, you know, 5 pods a week to 3 pods a week. When you come back in 2 months, when we see back in 2 months, is it okay if we see how things are going then? And if anything, if you're struggling with anything in between then, you know where to reach us, and you can always come on back in sooner. But really having not so much a sense of accountability, but a real team effort, and knowing that there's going to be that follow-up message can be helpful for families, especially in the hecticness, which is life when you have a under 1 year old in your household. And it is useful to kind of help remind families that little steps are important. I mean, even if those steps are about minimizing the direct exposure and working closer and closer to an ultimate full smoking or vaping ban in the household or in the cars, in complete quit, all those little steps make a difference for the health of the child as well as for their sort of ultimate hopefully goal of quitting completely. We mentioned some of the resources. You have the Quit line as one of those very physical resources that you can pass on to families, refer them directly in terms of using the referral form, but those families also can just call the Ohio Quit line, 800-QUIT-NOW directly. They don't need your referral to access the Ohio Quit line, but that is just one other way that they can get it done. They can also, again, they don't need your referral, but they can go online to the Ohio Quit line and start their coaching going. We've also mentioned the My Life, My Quit, which is an offshoot of the Ohio Quit line, specifically geared to the under 18 set. So it's a teen focused, but for many of you, you may have families that kind of fit into that category. So that may be a good resource. There's also some additional government resources like the Smoke Free Text and Ditch Jewel, again, more adolescent focused vaping resource, but text messaging and sort of counseling support via text to help with quitting vaping, but certainly a lot of those habits correlate with traditional tobacco cigarette support as well. So those are some resources. And just know, again, as we think about some of the other practices, primary care clinics, just like you and me, who have gone through this program, what they've told us in terms of what's been really helpful for them in implementing the program itself, implementing the resources, having conversations with family, and what we're seeing from the data that Mike has mentioned as well in terms of how effective that has been in reducing smoke exposure for the kids who this program's lives has touched, and for those families, that for those adults also reaping the health benefits of reduced smoking and vaping as well. And just opening that door means a whole lot to patients and their families to be able to talk about quitting.